I'm Dr. Navaneeth from Aravinda Hospital, Coimbatore, no financial interest. My objective is to evaluate efficacy and patient comfort of Wick-based anesthesia versus conventional methods in phacoemulsification surgery. It's a prospective randomized control trial, 120 patients with 60 patients in each group. Group A allocated for Wick-based anesthesia using cotton wick saturated with 0.5% propagaine for 3 minutes, and Group B for standard anesthesia using topical 0.5% propagaine drops for 3 minutes. All patients above 50 years with no prior ocular surface disease and no prior surgery are included in the study, and patients who are allergic to anesthetic agents and who are inability to provide informed consent are excluded from the study. This is the methodology. The video is not playing. Excuse me. नहीं है. From a sterile bin, a sterile cotton pad is taken onto a tray, and from that a thin, slender and little lengthier cotton wick is made, and this wick is soaked with 0.5% propagaine drops. And this soaked wick inserted into superolateral fornix, not the superior fornix. Superior fornix will cause epithelial defect with the blinking. It is inserted into a superolateral fornix, followed by betadine drops installation into the eye. And after this, patient is asked to close the eye for 3 minutes. And over that patient is taken into the table, the wick is removed, and the routine sterilization draping is followed, as like in any other topical anesthesia. Primary outcomes are measured with patient comfort with visual analog scale, intraoperative pain with numeric rating scale, and secondary outcomes are measured with surgeon satisfaction and anesthesia onset time and postoperative recovery time. And the standard softwares are used, demographics kept same in between both groups. Primary results are patient comfort in Wick-based anesthesia is 9.2 compared to topical anesthesia 7.8. Pains rating is almost half of the topical anesthesia in Wick-based anesthesia. Group A is 1.2 with Group B is 2.4 pain score. Secondary results, anesthesia onset time was faster in Group A with 2.5 minutes onset time. Group B it is 3.7 minutes. Surgeon satisfaction is higher in Group A with reduced ocular movement. Post-operative recovery and complication rates are comparable in both the groups. Coming to the discussion, we know that topical, we can only put 1 drop into the Coulde sac, remaining drops will get spilled over, whereas with wick-based anesthesia, we can take up to 14 drops with the help of the wick inside the eye. This results in a faster onset of action as the dose is more. And with the eyelid blinking, the topical drug gets washed away, whereas in wick-based anesthesia, it gets released into the tissues, resulting in a longer contact time. In topical anesthesia, the drop will be just above the epithelium, whereas in wick-based anesthesia, it is sandwiched between the upper lid and the sclera, resulting into the deeper penetration of the drug. As we are inserting into the area superolateral fornix, where the squeezing muscles and Bell's phenomena are very active, we reported less squeezing and less Bell's phenomena with wick-based anesthesia. These are the advantages. We can take more amount of drug with faster onset of action. Blinking and eyelid closure results in longer contact time to the tissue. Sandwiching results in deeper penetration with and where the location itself reduces the squeezing and Bell's phenomenon during the surgery. Conclusion: Wick-based anesthesia is effective, patient-friendly, improves surgical outcome, and it is very cost-effective. Recommended to integration in routine surgery protocols. Strength is it is a prospective randomized control design. We used validated scales, comprehensive outcome measures. Limitation is in this study we used 120 patients. It's a single center study. long-term outcome yet to measure. Future directions are, we have to take this to, we want to take this to large multi-control trials, and long-term safety and efficacy also yet to be assessed, and applicability in other non-cataract procedures also we want to assess. And now our lab is making a pre-soaked and sterilized wick like a fluorescent strip. We can just open and insert into the superior lateral fornix. Thank you.
Yeah. So this, I wanted to ask, have you noticed any toxicity of corneal epithelium, because you're using, like you told, 14 times the drops versus single. Have you noticed any toxicity on the cornea?
Yes, sir. It's a longer contact. If it is more than 3 minutes, we observe little corneal change.
But that is important, no?
Yes.
That is an important finding.
Yes, sir. Very important.
Thank you.